Moira Stiles there. There's an enthusiasm, I think, for this 3-month and then later 6-month reassessment process, and the argument is, or one of the arguments is that it's likely to produce more data. Are we short of data?
I think the big advantage of the review is that we can see if it's actually working. I mean, I think Moira commented on the increasing prevalence of people with malnutrition. I think the more likely cause of that is that people are surviving long with debilitating illnesses, that malnutrition or loss of weight is a core component of people with chronic obstructive respiratory disease, heart failure, dementia. All are associated with weight loss, and people with those conditions are surviving longer. So I think we will see more people with this problem. Often those situations don't respond particularly to supplements, and it's therefore very necessary to actually monitor whether or not they're effective.
I think the supplements have a role to play with the food first, so that they're not the answer to actually solving the malnutrition problem, but they have a useful role to play to do exactly that, to supplement the food that people are eating, and so that they shouldn't take place of the food.
Moira emphasised that it's imperative to use a tool that's validated for the age group, and I assume that it's also just as imperative that the tool is properly used. The data obviously have to be accurate. How much of a challenge is this in practice? It's
a big challenge. The MUST tool that we talked about earlier asks for a body mass index, which requires patients to have a height taken. And for many patients, that can be quite difficult to actually straighten them up and get a height or have them standing in the first place. So MUST also gives other ways of actually taking height for patients that are either bedridden or can't stand up. So using ulnar length or knee height, those sorts of things. So I think so long as staff are well trained in gathering the data appropriately, that's probably the key to making sure the tools are used properly.
Right now, how often do you find that the measurement tools are incorrectly used?
Well, they're not used widely. I think that's probably the crux of it at the moment, is that they're not being implemented in New Zealand widely. And the MUST tool has been validated across the continuum of care for acute care, community, and also for aged care as well. So that's another reason that it's a good tool to be using. It applies to all of those age groups and can actually be tracked through a patient's journey.
There's one big issue too with the assessment of body mass index, and that is that you can get protein malnutrition in older people who actually have quite a large body weight. They've got obesity, but they've actually lost muscle bulk, so-called sarcopenic obesity, and that can be a real problem. So BMI is not necessarily
well, you've got there before me. Yes. You've got there before me, because I was going to ask whether the malnutrition definition is going to be a kind of one-size-fits-all situation. I mean, do we know, and I'm sorry, that's not meant to be a pun, do we know whether the malnutrition definition is going to be appropriate for all age groups?
No, it's not. And I mean, what is very important is change over time, and that's where we really rely on the general practitioner who's been seeing the patient for some time and picks the change.
See, I mean, I think we're talking about two distinct groups, and one that I think has been neglected in general practice. A group that we have tended to focus are already malnourished. They are the people that John's identified. They have a terminal disease. They have cancer. They have terminal heart failure, terminal respiratory failure. They are what we term cahectic. We often have used food supplements there, and I'm not certain why. What are we trying to achieve? Then there's a group that I think that's now starting to be identified, those who are at risk of becoming malnourished. Perhaps that's where we have to focus on identifying those and trying to get in to prevent, because by the time they're in that malnourished state, particularly after the terminal disease, what are we trying to achieve? And I come back to the point that John made. Socialisation around food is an important part of life, and I think it's not necessarily how much the patient or the person being cared for eats, that's part of that social pattern. And I think if we can get that food first message across, it's really important.
Accepting the importance of that, do you see any problems or issues involved in following the food first line?
I think the issues that the carers, the family, be they the spouse or the children or the kindly neighbour, what they're looking for is some guidance on what they can do. I remember back in the 80s, we used to have a number of recipes we would give, particularly to the partner of someone who had cancer, and it involved bananas and the various baby products, and they actually used to enjoy making them and preparing them. And I think what that's what Alison Holst and Simon were trying to point out. So I think general practice, the team, would really gladly take some guidance on simple things which can be given, and then the referral process into community dietitians. But one of the questions I've got for John is, what about appetite stimulants? Dexamethasone, steroids, particularly in cancer patients, often given to make them feel better and increase appetite.
I think in very specific circumstances, as you mentioned with cancer, for example, or a person with hypercalcemia, but not as a general rule. And as you're aware, I mean, the adverse effects from steroid use inappropriately can be very considerable.
Okay.
Do you think sometimes we're using these supplements as a sort of like a magic pill? You know, you give somebody almost a placebo. Do you think we get into that a little bit with some of these?
Yes, I think we're seeing situations where the person is losing weight, they're losing condition because of their underlying medical problem, and people feel something must be done, especially when it's something as basic as nutrition.
Yeah.
And the staff in a rest home or the family feel better if they're doing something such as providing a supplement. But the evidence around benefit in that situation is very soft.
But I think your new guidelines too, Peter, actually give very clear guidance for people in that situation as to when the supplement should be used. Yeah. So going back to Murray's point about what do GPs advise for very simple, you know, food first. Food first is small, frequent meals. So 3 meals a day, snacks in between. Start there. Bang for buck, making sure that people are getting good nutrition for the food that they're eating. So trying to incorporate high protein, high energy foods wherever they can. Something as simple as adding cream to porridge in the morning, or, you know, extra butter on that toasted sandwich that the Holst had. Those sorts of things will go a long way.
So all the things we've told them throughout life is bad for them. You have to actually change and tell them it's now good.
That's a great advantage. Yes.
So part of my job I love, Murray, really, because we're dealing with different circumstances here where, you know, we're really keen to get extra energy and protein in. And yes, where you can get the heart-healthy fats and oils in, then by all means do that if the patient accepts that.
But for what reason?
Well, if that's going to help them increase their immunity and feel better for the time that they have, then I think that's very worthwhile.
So is this when you're talking about food fortification, you're talking about adding cream?
Well, that's one aspect. Grated cheese onto vegetables, a dollop of sour cream on the baked potato, those sorts of things.
And butter is no longer the most toxic substance out of New Zealand when you reach that age in life.
We're talking about malnutrition here. So for somebody who's been identified as malnourished, no, it's not a toxic substance. It's not that toxic for anybody else either.
So it's cheese in your mashed potatoes. It's cream on your porridge.
Those sorts of things. Making sure that they're having a snack.
Yeah.
Yes,
Yeah.
a good milk pudding, and having pudding as a snack if they can't manage it at the meal. So
But
custard
not
or
assuming
fruit.
that salad is the right way to go.
No.
Salad's great if you put good dressing on it. So again, you're adding extra calories in that way. So variety is still important. They need those extra vitamins and minerals coming from all the food groups to actually be able to use the energy and the protein.
Murray just can't wait to get old.
I am old, Peter. So what about... So we've talked about fortification for those who are malnourished, but the issue that I think as a general practitioner I have neglected is those who are at risk, and we've heard about the high, medium and low risk.
Yeah.
Do you see that as an important group that general practice needs to start to consider?
Absolutely. I think stopping that cascade of malnutrition is quite important. So if we can identify them early and put, as Julian said, those simple practices in place first, actually even highlighting it to the patient and their family can go a long way to say this isn't the natural progress of getting old, it doesn't have to be this way, that actually increasing the frequency of food that you're eating and making sure that it's nourishing food that you're eating can go a long way.
Many of us, though, have observed over time that it does appear to be the natural progress of getting old. If you live long enough, you get skinny.
Well,
You can certainly lose weight, but there's no doubt also that if you are malnourished, if your body weight is down, especially your muscle bulk, then you do less well in any acute illness or any acute surgical intervention. So it's important in terms of reserve.
Supposedly overweight person who's lost muscle bulk, simple tests, can they arise from a chair? So proximal muscle strength testing,
yes, that sort of
simple
test is
tests
quite
in
important.
practice.
Yes, yes.
I'm looking in the direction of the audience. Are there any questions? Yes.
I'd like to thank you for the opportunity to ask some fairly practical questions. This is directed mainly to Peter. There are obviously a lot of people out there that have already got authority numbers for special foods, and will they be expected to go straight over to the powders, or will they continue until those numbers have expired? Secondly, and supplementary question to that, because you've gone to a lot of trouble to make access to the authorities very straightforward and online, but if Of course, we can't do that for special foods now. It's an instrument that doesn't work anymore. So do you have any comments on that?
Let me answer the second one first. Electronic Special Authority for Special Foods is now back on, although I regret to say the dietitians still don't have access to it, but Sector Services is working on that. Your other question is, can people continue on with their liquid foods if they've been on it before? In other words, can they be grandparented? The answer is that the rest of their prescriptions, their particular prescription will be grandparented, but then they will have to change over to the powders.
If they choose to.
Any other questions? We've got a text question. Let's take that now. It's from Sean, who's from Porirua. Why is the only palatable special food, Fortisip, now only partly subsidised and hence not affordable for people on low incomes? Peter.
Well, there is in fact more than Fortisip, but it is a fact there that they're going to have to change over to the powders. And the powders are certainly a little bit more inconvenient, and I'll have to admit that. But they can be flavoured, and perhaps you could tell us a little bit more about that, because I don't think that's very difficult, is it?
No, I mean, they get mixed up either with water or milk to a milkshake, and the idea is that you can add extra flavourings to that. So you can use something as simple as Milo or coffee, products that we probably all have at home, adding another fruit, so again another way to get extra nutrition in, using bananas or canned peaches, something like that, to add the flavour, so making more of a smoothie. The point about Fortisip being the only palatable product, I think, is a valid point, in that these are foods that we're talking about and everybody has a particular taste preference. So what suits one patient isn't going to suit everybody, and it's a case of playing around with the products that are available and within the financial constraints of the patient to actually make sure that we're doing the best we can for them.
Sure. Is there any any difference in therapeutic effect as between the powders and the liquids?
No. I mean, there's been no trial that's shown any benefit of one over the other.
So the difference is about portability and convenience.
And convenience, that's right. And as Peter said, well, Stu said, I mean, it's very much an individual preference. Fortisip, in actual fact, a lot of people don't actually like it. They find it too sweet, they find it too milky. They actually would much prefer a milkshake or a smoothie or some other product such as that.
I think the other point too, though, is that those liquid supplements, if that's what people are preferring, can still be used in that same way to make smoothies. So there's a lot of leeway or scope for people to actually make the products as palatable as possible. You don't just have to drink them straight out of the container. You can add those extra ingredients to make a smoothie out of them as well, as you can the powders.
When you look at the use of these products in rest homes, have you struck in the course of your practice resistance from the rest homes in making powdered supplements up?
No, not as such, because again, with the rest homes I work with, they're making milkshakes and things anyway, because we try that as a first-line approach. I think the key thing for anybody who's mixing up the powders to be aware of is that there is a food hygiene risk here, that you have to treat them as a milk product. So, you know, equipment needs to be clean, that once they're mixed up within 24 hours, they need to be discarded. They can't be kept in the fridge for a week. So there's not resistance there, but there needs to be good practice and policy in place in how the products are used in a safe way within those environments.
Well, just to close this down, Murray, I'm looking in advance, which is really unfair, for a balanced scorecard assessment of this new regime. How do you think it's going to work out in practice?
I think it's going to work out very well, but like any new regime, there's going to be a settling down period. And when general practice has not been used or been allowed access to prescribing these products, we've not had any incentive to understand them. Now, I mean, tonight, for instance, I understand more about cow's milk allergy than I did earlier tonight. I also understand more about food first. I understand, for instance, that we're mostly focused on the already malnourished and we need to move back a step.
Thanks for that. That's this edition of Health Q. Thanks to our panellists, our studio audience, and a special thanks to you two for texting us your questions. And just a reminder, this prescription foods handbook will be sent out to health professionals over the course of the next week. Thanks for joining us tonight. Go well. Good night.